I'm going to do a quick introduction. I wanted to thank everyone, Anastasia and Basha, for giving us this opportunity to talk to our colleagues across the Atlantic Ocean. I've been working with InGenius now for a number of years and always find what InGenius does to be very remarkable and unique. And I hope you guys enjoy our talk today. Dr. Williams and I have been working together for the past couple of years. I find him to be a very extraordinary person, human being. He's been a paramedic now for well over 10 years, great experience out in the field. Currently right now completing his residency at Queen's Hospital. And ultimately, I think his expertise and experience in the evaluation of the trauma patient is a very unique one, and I hope you guys enjoy it. I will be also doing my part as a gynecologist, offering you my expertise about how to evaluate the trauma patient who happens to also be pregnant. So I hope you guys enjoy it. And as far as questions, feel free to free text any questions and we will answer them at the end, and enjoy.
So I'm Dr. Williams. A little bit about me. A lot of this presentation has come over the years working throughout New York in acute trauma situations, and kind of coming up with an approach that's really based around fundamentals of knowing your resources and knowing what's around you in terms of facilities and capabilities, because ultimately that's what's going to determine the outcome of your patient, is to bring them to the right facility and give them the right treatment in the least amount of time. And that's actually been shown to correlate with better patient outcome. And so there we go. So, and you always want to start with the basics. I'm a big fan of the basics. So BLS before ALS, basic life support. Your basic life support training is going to basically not only save your patient's life in the short term, but ultimately lead you to the right triage and disposition at the end of the day. And you want to take into consideration your dispatch information, and that would be the information that comes from the call. You know, you're responding to an emergency. It's going to tell you the where, the when, the who. And you want to pay attention because any slowdown for you to approach your patient for the initial assessment is going to correlate with your ultimate outcome for your patient. Scene safety, survey, hazards, resources, supplies, and triage. These are things that are really native to EMS response and separate from other medical settings, is that you have to be aware of all of the dangers, not only of your patient, but for you and for your team that's on the scene. So for example, if you're in a large MVA, you have to make sure that, you know, there's no active fires, that you have firemen supporting you in the background and making sure that there's no gas leaks. And if you're in a war zone, you have to also make sure that you're staged an area safe enough for you before you can actually go and approach your patient and deliver the appropriate care. And that's essential. You want to take into consideration all the supplies that you have, because not every EMS setting is going to be the same. So depending upon who you are providing your EMS services for, emergency medical services for, is going to depend upon what resources you really have. So if you're working for a large institution or a large hospital, you may have more things ready for you on the ambulance in order to intervene acutely, as opposed to a smaller rural setting. So it's all about prioritization, because when you think about it, it's really going to depend upon the number of patients, the nature of the injury, and the distance to the qualified hospital. So you're going to have, you know, multiple categories of trauma patients. For the purpose of this presentation, we'll focus on trauma patients, OBGYN trauma patients, and also those medically compounded trauma patients, where oftentimes you're not only just dealing with, let's say, a victim of an MVA, a motor vehicle accident, but you may be dealing with a patient who's had an, you know, a myocardial infarction, and then you identify a STEMI, and you also have that trauma piece at play. And so knowing where your facilities also for your pediatric patients are going to be important, because all of these are different specialties that require different resources. And ultimately, you have to end up at the right one first, because if, let's say, you go to a facility that's not capable of intervening acutely to save a limb, it doesn't have vascular surgery services available at the institution. Well, then now it's delayed from the point in time that you picked up the patient and dropped off the patient. You manage them in the acute, control the bleeding, but now another transfer has to be arranged to the facility that would be able to do the vascular intervention. So if you initially end up at the right institution off the bat, you're doing your patient a service. Ultimately, you want to know your basic sample, OPQRST history, past medical history, allergies, medications, hospitals, most recent immunizations, trauma, sexual history, family history, obstetrical, occupational history, social contributors, smoking, and supplemental information. And this is so much more important than just, I know, we're speaking to a lot of physicians here, and I know that this is really our bread and butter, even on the floor, but even more so when you're in the emergency medical setting, because you don't have access to the patient's chart or EMR. And so all the information that you're going to be working off of in a real-time diagnosis, it's not going to have, a team of 7 other physicians that have rounded on the patient with you to come up with a definitive diagnosis and the proper disposition. It's just you. And so what you need to do is get all the information that you possibly can in real time, analyze that, and ultimately secure which facility would be better served for your patient. So in patient examination, and this will reflect on a recent change, and I really think that this one applies to the trauma patient more so specifically. The AHA actually endorsed a couple of years back a CAB approach instead of an ABC approach. It was predominantly in the lay CPR provider setting and the lay BLS setting, where you would do circulation, airway, and breathing as opposed to the traditional airway, breathing, circulation. Some larger institutions have also gone into this frame of thinking where you want to control life bleeds first, or you want to make sure that there's no delay for CPR. Years ago, when I first started working in the industry, we always used to check for rescue breaths, and then we would reposition the airway, and this whole time CPR wasn't going on. And so AHA revised their guidelines and said, well, you don't want to increase the time from the first push on the chest. You want to make sure that you have circulation happening outright. And I thought that this was a good frame of mind to keep in mind when we're dealing with our trauma patients. So if you do want to really control those life-threatening bleeds, a lot of this happens in tandem. However, you want to make sure that for example, if you have a femoral artery that's damaged and your patient is bleeding out actively, you want to control that bleed first, and then you want to manage the airway. Hopefully you have enough people on scene where you'll be able to do those in tandem. But this is just something for you to keep in mind in terms of prioritization. When we're talking about circulation, especially in the trauma patient, once you've secured your scene and you've staged an area where you're going to try to apply your acute interventions and then ultimately come up with a disposition, you want to control life-threatening bleeds and with direct pressure bandages, of course, as we traditionally are. But we really go to tourniquet a lot faster these days, especially in the field in New York. And it's because of the research based around applying a tourniquet that we once thought if you applied a tourniquet to a limb, you now had very limited time to get that person to somewhere that would be able to intervene vascularly. But that actually turns out not to be true. And so through the review of the literature, we actually know that it's up to 2 hours before you'll have any lasting neurological damage or vascular damage if you had to apply a tourniquet to a limb. So for example, if you have a high pressure bleed from an arterial wound and you wanted to apply that tourniquet because you were having trouble managing the bleed in the acute, you could do it faster than you once could, because you used to have to apply pressure, then a bandage, then a hemostatic pressure bandage, and then you would go for the tourniquet after that, right? So you can go right for the tourniquet if this bleeding looks significantly enough to threaten life. And there's a couple of different ways that you can do this. You could use the windlass technique, or you could use, there's consumer products available as well as the military products that are available. And it really depends on what kind of resources are located in your specific region or area that you're serving. But the best really trick is, if you look at the bottom portion of the slide on the right, this always works. It's basically a cravat bandage and a dowel. Okay, and you tie the knot under the cravat bandage, and then you tie a knot over the dowel, and you connect the two cravats and make sure that it's 2 inches proximal to the wound in order to be able to clamp down tight enough on that tourniquet to stop the bleeding arterially. And you just tape it. Once you've spun that dowel that's connected to your two cravats and you tape it in place. It works every time, so that doesn't matter what geographical area you're in. You could stop the bleeding outright. And when we're talking about airway, we've got to remember that when we're managing the BLS, the ALS airway, we first want to manage it with Bls maneuvers. And so you want to use a jaw thrust, which is where you look at the picture here, you're only manipulating the mandible as opposed to manipulating the cervical spine. Because one of the things that we know about the trauma scene is that a lot of things could have been at play. And if we can't identify that there was no cervical damage, then we shouldn't be manipulating the neck at all. And so we'll do the jaw thrust first. And you want to apply an OPA and MPA in order to remove the tongue from the oropharynx. And this will really facilitate better BLS airway management, which can ultimately give you more time before you have to intercede with an ALS airway intervention, such as endotracheal intubation or supraglottic airway insertion. And when we're assessing breathing, let's say, now we've opened up the airway, we've managed the life-threatening bleeds, and they're just not oxygenating well. We'll measure that with an SpO2 in the field. And you want to really have a target of above 92 on the SpO2, which is oxygen saturation in the blood. And you assist breathing and measure the oxygen that's needed appropriately. So nasal cannula, you can give 2 to 6 liters per minute. Non-rebreather mask, 12 to 15 liters per minute of O2. And the bag valve mask, as we all know from using it in a cardiac arrest, is going to give us our 100% oxygen as needed. And again, when we're determining the nature of the disability, and there's a couple of maneuvers to do this. My favorite is to assess the AVPU. So are they alert to what? Physical, verbal stimuli? Are they alert to the sternal rub, to pain? Do they open their eyes? Are they completely unresponsive, which would obviously tell us that we needed to hasten our transportation time to the next disposition. And for GCS, the Glasgow Coma scale, you really want to make sure that you remember less than 8 intubate. And if you're not familiar with the Glasgow Coma scale, I encourage you to review it, because this is a quick way to understand when you have an impending failing airway. And so if it's less than 8, the patient's altered mental status, actively difficult, you're looking at an actively difficult breathing patient where they're struggling to respirate, then you use the GCS along with the entire clinical picture to decide that it's time to intervene. And then you could assess the pupils, symmetric, asymmetric. This is going to tell you, again, about our medically compounded trauma patient, where if those pupils are asymmetric, and then that was before they drove their car off the highway, then you're going to have to bring this patient, or if there was a large amount of trauma to the head and you're thinking about a subdural bleed, you may see pupillary changes, then you have to go to a facility that has neurointerventional capabilities, such as a clip and coil facility. And if there's a stroke component, then you may have to go to a stroke center, which only certain facilities are really capable of pushing TPA, which is the thrombolytic used in strokes. So for continued assessment, you always want to make sure that your patient never gets ahead of you. Check the vital signs, blood pressure, skin color, temperature, condition, blood glucose determination, because that may very much, tell you the difference between a stroke presentation and a diabetic patient. And advanced directives, of course. So proper destination choice can really save the patient's life or increase mortality, depending upon which decision you make and if you've triaged correctly in the field. And so OBGYN services, for example, that's a great example. If you're looking at the tachometer, which we'll go over a little bit later, and you see signs, and even the whole clinical picture tells you that there's a high likelihood for maternal and fetal hemorrhage, then you may very well have to know which facility is best equipped in order to provide those services for a better outcome for mom and baby. So also, the same thing is true for trauma services, neurovascular services, pediatric trauma cases, STEMI cath and lab availability. And this should really be something that when you're in the field and delivering emergency medical services or working for the facility that's planning to start doing emergency medical services in their area, that you really have an understanding of everything that's around you in terms of where and how far the transport times are to each trauma, neurovascular, pediatric, STEMI, and OBGYN specialty services providing hospital. So when we're going for the ALS airway, this is really an important part of managing the trauma patient, especially from the point in time where you package the patient up, you put them on the ambulance, and then you're heading into whatever facility you've appropriately chosen. And one of these things that's really been used in the field and more effectively as of late, especially in the New York EMS system, has been rapid sequence intubation. And so your ET tube, you want to consider the formula for the size of the ET tube. A quick way to do it is to look at the patient's pinky finger, as long as it's non-edematous, non-swollen, no trauma, lacerations that would offset it. And you'd be able to come up with the size, but we'll go over the official formula on the next slide. But you also want to have a supraglottic airway ready, because if let's say you have anatomical variations that make securing the advanced airway difficult, you need a backup plan in order to facilitate the airway. The paralytics that we use in the field most commonly here, succinylcholine, contraindicated in hyperkalemia, and rocuronium. So succinylcholine is generally preferred because of the shorter half-life, and rocuronium can actually be used in order to maintain the paralysis state for longer because of a longer half-life. You can induce with ketamine or etomidate, traditionally etomidate 20, contraindicated in adrenal insufficiency. So you really have to, again, go back to the history. That one opportunity to take a history, not only from the patient, but also from bystanders of the patient, from family, from whoever's present, is going to give you these little keys for you to move forward and appropriately treat the patient. You can induce, after you induce, you could use sedatives and analgesia to maintain that tube until you get to your destination. So midazolam, Versed, fentanyl. Maintenance is ketamine. So you see ketamine a couple of times in here, and if you have access to ketamine, it's a great drug. The only problem is there's no reversal agent. So a lot of people kind of stay away from it. Whereas opposed, you could use midazolam and fentanyl in the field, and as long as you have naloxone, Narcan on board, and there's also a reversal agent for midazolam, which is quite expensive but available at some institutions, then some people actually prefer to go with that. But if you did have ketamine on board, you could literally induce and maintain with one drug. And so that's convenient. In my experience, I usually go 21 centimeters deep on the endotracheal tube once you pass it through the vocal cords. Now, when you're using direct laryngoscopy and you visualized the vocal cords, you want to go 21 centimeters deep for women, and most often 23 at men for the teeth, in my experience. Again, other formulas you can use for the ET tube size. For an adult, it's age divided by 4 plus 3.5 with the cuff tube. For children, 16 plus age divided by 4. These are uncuffed tubes traditionally, and that's due to the anatomical variation that their airway is going to actually not require a cuff in order to secure it in place. You should not RSI pediatric patients unless you've received specialized training for that. It's very difficult. The proportions in their airway are very different than an adult. And you always need a backup plan if you're going to RSI in the field, which is why I mentioned the supraglottic airway. But of course, and I like the King airway most often, and it's because it blocks off the anatomy above the esophagus. So the only airway entry port that's left is into the trachea. And these can stay in for hours and hours. Some guidelines say 6 hours. The needle cricothyrotomy after you paralyze the patient is an important piece, because if you can't get that airway and that patient's paralyzed, you ultimately, failure is not an option. And so if you have failed to secure your endotracheal tube and do not have a supraglottic airway, you must do a needle cricothyrotomy, or else you've killed the patient. So indications we had discussed, and another real good point that I put on this slide for why you would consider RSA in a trauma patient is because these patients may have an intact gag reflex but have an impending failing airway. But also when you use paralytics in a patient who may have an increasing intracranial pressure because they had sustained massive head trauma, you can suppress the vagal response. And this ultimately can suffice as a way to decrease the amount of spiking ICP that's associated with general intubation because of the vagal response without the paralytic. So it's not GCS less than 8 in a trauma patient and then intubate. It's GCS less than 8 in a trauma patient paralyzed and then intubate. IV and IO access, the bread and butter of emergency medicine in the field. You do not access the limb where there's a fracture or disruption of the vascularity. So just go on the other side. If you're dealing with, for example, a right upper extremity fracture, you would obviously secure vascular access on the left upper extremity first. And you would use the intraosseous drill, which is the EZ-IO or the Jamshidi, which is less favored. And this is just a drill that can insert the piece into the bone. You secure and confirm that you've been through the marrow, and then you can deliver fluids directly into the patient. So IV fluid to increase the blood pressure. 2 bilateral IV gauge, 18 gauge IV lines increase the amount of fluid that you're going to be able to administer. In fact, you can give more fluid faster because of the size of the catheter of IV 18 gauge than you can in a central line. And so if you have 2 peripheral IVs, then you just work with those. Recent studies do show that our isotonic fluids, traditionally it was, we'd be hanging liters and liters of bags in order to bring up the pressure of the circuit to try to increase end organ perfusion in the trauma patient that's suffering from hypovolemia. But however, if there is blood products available, and I know a lot of people may be working in hospitals that have these things that you can put onto the truck, or at least in the future, if you find yourself managing or working in one of these hospitals, you could use blood products in the field, and that's shown to increase and improve patient outcome. So I do have a video here. Let's see if we can get it playing. So this is just an example of how to use EZ-IO. This is my favorite
I'm Dr.
tool.
Jess Mason, and this video is going to show you placement of an EZ-IO in a real patient, in a real code, in a real hospital.
So I just want to show you the technical aspects. I think she does a really great job of how to do this. And I'm not sure if you have these devices available, but I'd recommend them. So it's 2 finger widths below the patella, and you go a little medially. And what's interesting about the anatomy of the tibia is that it kind of almost buckles, and you'll see right there at the entry point, it's almost going to buckle and secure this IO in place much faster than looking for an IO in a severely hypovolemic trauma patient who's actively bleeding out, because as you would imagine, the vascularity in that patient is going to be difficult to access, as they probably are volume down. And so this is really a great option for you. So you just drill. And as soon as you feel resistance, you know that as soon as you feel less resistance, you know that you're likely in the marrow. What she's doing right now, she's aspirating that marrow. She's going to look in that hollow bore needle that she just pulled out and make sure that she's in the marrow. And then you attach a connection to this piece. And then you can infuse fluids, drugs, whatever you need through there. So anyway, moving forward, pain and anxiolytic management of the trauma patient is crucial. One of my favorite agents to use is fentanyl because of the route that you can deliver it. So intramuscular, intranasal, 1 mic per kilogram is your max. This really goes a long way. And you also have a reversal agent, although it's less effective in fentanyl than it is for, let's say, morphine. But naloxone will work. And morphine IV, 5 to 10 milligrams. Midazolam IM IV, 5 to 10 milligrams. And Versed IM IV, 2 to 4 milligrams. Now, something about morphine, what I like about it, especially in the trauma patient, is that you can actually, let's say you have a medically compounded trauma patient, which is not uncommon, and you now have myocardial infarction at play. You could also decrease the afterload and stress in the heart at the same time. But as are a lot of our trauma patients are hypovolemic, you want to be careful about that vascular dilation. So moving on. Okay. So an EKG management, actually a very important part of the pre-hospital assessment of a patient, especially in the acute trauma patient. And I like to use the Sally approach, and that's really when we take a look at the precordial leads, coordinating it with the anatomy of the heart, and ultimately helping us to arrive at the disposition and the correct transportation to the facility that's going to be able to optimize the care for our patient. And so when we think about the Sally approach, we look at the septal wall, what leads V1, V2. We look at the anterior wall with V3 and V4, the lateral wall with V5, V6, and 1 in AVL being upper and lower lateral, and the inferior wall, 2, 3 AVF. And traditionally, the septal wall, as well as the anterior wall, are predominantly provided circulation from the left anterior descending artery. The lateral wall is provided circulation from the left circumflex artery. And the inferior wall is provided circulation from the posterior descending artery, which 80% of the time, as it's traditionally taught, receives most of its circulation from the right coronary artery. 15% of the time, it's from the left coronary artery, and 5% of the time, it's from both. And that's the guy that survives the widowmaker, that fully transmural myocardial infarction. So let's say that's a 32-year-old male patient after a high velocity car versus car accident, unrestrained, complains of chest pain. And you have to come up with the answer of what's the most appropriate disposition besides managing his acute injuries for this patient. And so when we look over here at this EKG that I put on the screen, you could see something that's strange. And these peaks here, if you could see my arrow on the screen, which I believe you can. So these are varying QRS heights, okay? And you can also see that there's low voltage in QRS. And when you look at this initially, you could tell that it almost looks like a T-wave abnormality as well, right? Peak T waves. But that's because of the variation across all precordial leads, across your leads specifically noted in lead 2, you could see that QRS height variation. And this is a finding that you might see in a trauma patient where you know that you might have cardiac tamponade. So cardiac tamponade would be bleeding into the sac, the pericardial sac around the heart. You can't really facilitate more than 200 cc's of fluid. And so this is an impending cardiothoracic patient. So then now you know that maybe not only would you do pericardiocentesis in the field, where you would aspirate some fluid from that pericardial sac, and that would absolutely be an option. However, especially if you had ultrasound on your rig, but you ultimately do need to go to a cardiothoracic capable unit. You need a cardiothoracic surgeon in order to facilitate this trauma patient. And as I had said, it's really all about the disposition. And I'm going to hand it over to Shawn, but I just wanted to really reiterate that shorter transport times means better chances of survival. So let's say you are transporting a patient to the original facility that your ambulance is working from, but they don't have the services that are available in order to provide the cardiothoracic intervention going from the last example that we had just spoken. Then there's 2 transfers that they have to wait for. And for interventional life or limb situations, your ability to perform that intervention in shorter real time will directly correlate with your patient outcome. Thank you.
All right, guys. So I hope everyone's still awake. Dr. Williams, I think, did a fantastic job. And again, I just want to make a point that the fact that you guys are able to, listen to this and really understand this in a completely different language, I think is a remarkable thing. And so I think you guys are absolutely wonderful. And let's just continue. One of the points that Dr. Williams brought up that I think was really important is the idea of disposition. Once you evaluate these patients in the field, which is really, we talk about the first encounter being the emergency room. Really, with trauma, the first encounter is the field, is out in the street, is out in the apartment, is really that encounter that the paramedics and the EMTs here in the United States and all over the world really kind of come into contact with. And that's why it's so important to make sure that the evaluation is as comprehensive and is as time sensitive as it should be in order to make sure that the appropriate care is performed and then disposition is carried out. So trauma in pregnancy, I think, is a pretty important factor. And even here in the United States, and Dr. Williams and I have often had conversations about this, is not as complete as it should be. In fact, as we're going to go into it, trauma in pregnancy is often something where the team will come onto the field, see that the patient is pregnant, and although they'll do the basics, they'll often basically stabilize and transport right away to the nearest facility, irregardless of whether or not that facility is the right one for that patient. So we're gonna obviously go over how to properly evaluate a pregnant patient and determine where they should be sent based on their evaluation. So why is it so important? You know, obviously, we're talking about a pregnant patient. We're talking about a patient that is very unique to all aspects of medicine, because when you come onto the field and evaluate this one patient, you're not evaluating one, you're evaluating two. You're evaluating the patient who's there talking to you, hopefully, or even if they're not talking to you, but you're also evaluating the baby, who is ultimately never able to communicate or give you information. And so ultimately, you have to be aware and available to really pick up all the information and evidence that's available to you to make the right decision. What's also pretty unique about pregnancy is all the various changes that you get during pregnancy. Physiology is important for any medical provider. I always was taught that in order for you to understand pathology, you first must understand the normal, the physiology. And pregnancy is super unique in that it is what we refer to as a supra-physiological state, a physiological state that's meant for superhumans. And so women do a remarkable job at making sure that they stay healthy. But in doing that, obviously, it changes, obviously, the environment that they're in. And so when providers evaluate a pregnant patient, they have to know what is normal for them in order to determine what is abnormal. In addition to, obviously, the supraphysiological state, what's so unique about trauma in pregnancy is that we have to take trauma extremely seriously for all patients, non-pregnant and pregnant alike, but for pregnant patients especially, even the smallest of trauma situations can have disastrous events for the baby. And I'll explain in just a couple of slides. So trauma during pregnancy, you can imagine, is not a common thing, but it does happen in roughly about 6 to 8% of pregnancies. And so the big three for the United States are domestic violence, which unfortunately represents the biggest one, motor vehicle crashes, and falls. So getting back to, obviously, the physiology of pregnancy. So nearly every organ of the body is affected, and it's affected not necessarily because of the baby, but also because of the hormonal adaptations that the pregnancy creates. I often refer to it as a constant stress in the body. And so it's a hyperdynamic state that primarily provides support for the growing fetus. It's transient. We're only talking about 40 weeks. And ultimately, once the changes occur, they will revert back to the non-pregnant state within roughly about 6 to 12 weeks after the pregnancy. What's interesting about the physiological state of pregnancy is that if you're dealing with the normal, average, healthy patient, it ultimately doesn't cause much changes to the body. However, if you have an underlying condition like asthma, lupus, hypertension, diabetes, you may actually see an exacerbation of the underlying condition. One of my mentors during pregnancy also often said that pregnancy is a 24-hour cardiac stress test. And so if there is any underlying cardiac pathology, you'll often find these patients getting worse during the time of their pregnancy. And so we're going to ultimately focus on not all the organ systems, because you can imagine this would take us all day, but we're going to focus on specific organ systems that are responsible for the hyperdynamic state. And so we're going to talk about cardiac. We're going to talk about pulmonary. We're going to talk about circulation. We're also going to talk about the GI system as it impacts the pregnancy, and also renal, just because all of these have, I think, extenuating circumstances when it pertains to trauma and how to evaluate it. So as far as cardiac, again, I mentioned a 24-hour cardiac stress test. Cardiac output increases in the pregnant patient by about 20%, and specifically during the first trimester. The majority of that occurs because of an increase in blood volume by about 50%. There's also declining vascular resistance. Blood pressure drops during the second trimester. As a result, the maternal heart rate will go up. Why? Because ultimately you have to get more blood out of the heart, and it has to primarily go not only to the normal organ system, but also this new organ system that's created during pregnancy, the placenta and the fetus. Supine position at term can lower the cardiac output by 25 to 30%, which is important, especially in the field when you're talking about coming to a patient who may be unconscious and not necessarily responsive and lying in that supine position. One of the first things you may want to do is turn them to a left lateral position in order to increase blood flow back to the heart and to the baby. If ever you're doing a heart exam, you may notice certain changes. So in addition to the S1, S2 sounds, you may also hear a third additional sound, a murmur. And in general, what you're looking for or listening to are systolic murmurs, just because of the increased cardiac output. Diastolic murmurs are always a abnormal pathological sign. So always, if you're going to assess a patient and you see or hear a murmur, expect that it should be a systolic one. Pregnancy could also change the EKGs. So we kind of, Dr. Williams brought over a couple of, I guess, examples of what an EKG would look like, let's say in cardiac tamponade. Well, you could see certain changes during pregnancy with EKG, and a lot of it has to do with the mechanical lift of the heart because of the uterus really kind of lifting the heart and really kind of turning it towards the left. And so you start to see something called left axis deviation. You start to see certain changes in the ST segment, T waves. And so you anticipate looking for that, because otherwise you may think that there might be some ischemic changes going on. What's going on? Is there an enlarged heart? So anticipate to see certain normal changes during the pregnant state because of the mechanical changes of the uterus. Lungs during pregnancy change. And so one of the more common things that I come across in my office in the hospital is this constant feeling of having shortness of breath. About 70% of my patients and 70% of all patients will often complain of dyspnea or shortness of breath during the pregnancy. It really kind of starts or peaks at the third trimester, but you may experience it even during the first trimester, and a lot of it has to do with the effects of progesterone on the brainstem. And so you start to have this sensation that you're constantly breathing fast, and so you can't take a deep breath in, or you can't catch your breath. Oftentimes, if ever you're evaluating that on an arterial blood gas, you'll often see a respiratory alkalosis. And so when you're talking about shortness of breath of pregnancy, keep in mind it's hormonal and it's also mechanical. The growing uterus puts a lot of pressure on that diaphragm and really prevents the pregnant patient from taking a deep breath in. And we often, quite often, see even atelectasis during pregnancy because of it. So I often tell my patients, especially in a non-trauma situation, take deep breaths, learn to exercise your lungs, learn to use certain situations where you're taking deep breaths all throughout the day. And so it's important that, when you come onto the scene and see a patient who's obviously been in some sort of trauma situation, the feeling of shortness of breath may be important. Obviously, you want to evaluate that for obvious reasons, but also keep in mind, know their history. Have they been short of breath during the entirety of their pregnancy? Is this something new? Is this something that has gotten worse? Hematologically speaking, again, going back to what I had mentioned, blood volume increases. And so as a result, one of the things you tend to see is this dilutional impact on circulation, this dilutional anemia that ultimately may mislead you to think that something may be going on as far as an ongoing bleeding issue. You may also see leukocytosis. So normally when we evaluate a white cell count, we expect to see something less than 10 to 11,000, depending on the laboratory that you use. Here, you may actually see with pregnancy a white count go as high as 16,000 cells per high-powered field. You also expect to see a small reduction in platelets as a result of the pregnancy. And so these are all things you want to take into account, especially if you have access to laboratory studies that once you evaluate them, you may think, well, what's going on? Is there something acute going on? Which you should always err, I think, on the side of caution, but also keep in mind that this may all be normal for pregnancy. It's also important to realize that pregnancy, because of the changes that happen hormonally, because of the changes that happen in the liver, is a procoagulant state. It's a thrombotic state. And so trauma in and of itself also compounds that by being an individualized thrombotic state. So when you take a trauma patient plus a pregnant patient, just keep in mind you're dealing with something that has a suprathrombotic situation. And so having access to interventions that may reduce that, like sequential compression devices that may help with circulation, might be something to consider if obviously the clinical indication is there. Gastrointestinal, the big thing that I want to focus on is really the relaxation of smooth muscle brought on by progesterone. And ultimately, as a result, you start to see certain things like decreased gastric emptying. You start to ultimately see decreased sphincter tone. And as a result, particularly to Dr. Williams' point, when you're intubating, you have to worry about aspiration. This is something that's unfortunately very not necessarily common, but is super important to realize. So the idea of a paralytic, something that ultimately will help paralyze the patient to further decrease that potential possibility is something you want to consider. The medications that Dr. Williams brought up as far as the sedatives, even ketamine is safe to give during pregnancy if the indication is there. As far as renal urological, that for the most part, I wanted to kind of really focus on, again, laboratory studies because of the impact of increased filtration through the kidney. You tend to see a decrease in creatinine. So if you're evaluating their renal function, you come across a creatinine that's even slightly lower than what you would expect for renal failure, expect that that might be the case, especially if you know the patient and especially if you know what their creatinine has been like in the beginning of the pregnancy. If you see a doubling of that creatinine, expect that at least 50% of their renal function is gone. And that could be important, especially if you're dealing with a hypovolemic state. So these are all important things that you want to kind of focus on, not only for understanding what you're dealing with at the time of evaluation, but also if you come across any ancillary studies that may change your management. The uterus grows all throughout the pregnancy. And so especially during a trauma situation, which is why it makes it so important for us to take this problem so seriously, the uterus is a target. And it becomes that much more of a target as you get into the second and third trimester. Keep in mind, the pregnancy during the first trimester up to 12 weeks is really a pelvic organ. It's blocked by the entire bony pelvis. And so the risk to the baby is a lot less as opposed to once you get into the second and third trimester, where it becomes really a mass that occupies the entire volume of the abdominal cavity. So when you're talking about direct trauma, indirect trauma, penetrating, blunt, that uterus is the primary focus. And not only the uterus, but also the placenta underneath and the baby. And what's interesting about the uterus when you talk about mechanics is that the baby kind of moves. It's a mobile structure. You move it, it'll move because it's literally swimming in all that amniotic fluid. The placenta is a static structure. And so you hit it in a particular way, believe it or not, even the smallest of impacts will cause a separation, which is the one thing that we always worry about when it comes to trauma, is the placental abruption, the placental separation that could truly have a life-threatening, life-altering impact on the baby and mom. Blood flow to the uterus is enormous, about 500 milliliters per minute at the peak of the pregnancy, which is usually by the third trimester. Pelvic vasculature, the vessels that support the uterus become engorged with all that blood flow. Keep in mind, vascular resistance decreases, more blood flow. And so they literally all become this open target for any potential trauma. So you have to take it seriously. And so it kind of goes back to that original point. The smallest of trauma situations becomes that much more imperative for the pregnant patient. So how do you evaluate them initially? I like to use the term code because it kind of breaks things down in a very simplistic way. C is complications of pregnancy. Know what's been going on during this pregnancy. Has it been healthy, unhealthy? You know, what is going on with the patient? Is there any particular issue you want to talk or know about when it comes to their obstetrical history? Do they have a history of hypertension? Do they have a history of preterm delivery? What is going on not only with this pregnancy, but with past pregnancies? Know what gestational age we're talking about. And that's going to also be important for disposition because there are certain hospital centers, whether it's here in New York City, anywhere else in the United States, or even in Kiev or the rural areas of Ukraine, bringing them to the right center will make the difference about whether or not they have the right neonatal ICU, whether or not they have the right pediatric team to take care of this baby, and whether or not they even have the right obstetrical provider to take care of the mom. So you want to get a better understanding of gestational age for that purpose. And then obviously, what are the event details? And that obviously comes into play whether or not you're dealing with the pregnant, non-pregnant patient. This is what you want to determine as the initial team to figure out what potential could be going on with the patient. Physical exam, you're focusing around the baby, but in addition, obviously, to the mother. And so gestational age is important. We're going to go over that briefly to figure out what the age of the pregnancy is. We're going to talk about the abdominal exam, how to appropriately evaluate that, the pelvic exam, which is important, which is something, unfortunately, the paramedic team doesn't do here in the field, not because they don't want to, but because of liability and maybe also because of training. But the pelvic exam represents one of the pivotal moments in the exam for a pregnant patient because it will determine whether or not a patient will go to center A versus center B and C. And then fetal testing, something we also should be doing in the field, which we unfortunately don't, which I think is important because it gives you more information about the status of mom and baby. So gestational age, we go over, you could do it in a couple of different ways. First, I'm pretty sure you guys are familiar, for those obstetricians in the room, Nagel's rule, which basically takes the last menstrual period, you subtract by 3 and add 7 to give you the due date. And then from there, you determine the gestational age. Fundal height, after 20 weeks, expect the uterus to be at the level of the umbilicus, and then thereafter 1 centimeter growth for every week of gestation. So for example, if you're 21 centimeters uterus, you're approximately 21 weeks. If you're 36 centimeters, about 36 weeks. Sonography is important if you're capable to determine the weight and gestational age of the baby. It's important to know viability, right? Because if you're dealing with a viable fetus, therein lies the urgency of the matter. If you're dealing with a pregnancy that is at 12 weeks, then I think, it's not necessarily as urgent. Obviously, it's urgent for the sake of mom's health. But once you hit viability at 24 weeks, that's where the panic occurs. That's where the craziness occurs. And therein lies, I guess, the importance of having the right team evaluate the patient, because 24 weeks, babies survive, therefore we get them to the best facility. And it's going to be important, again, you bring them to the better facility, because if you bring them to neonatal ICU that can't manage a 24-weeker, well, guess what? You're delaying transport to the right facility, and therefore impact of health occurs. It's also important to remember certain numbers. So statistically speaking, what happens at 24 weeks? Well, about 60% of babies will survive if you put in the right team. Unfortunately, 90% will have some sort of disability. And then compare that to what happens at 32 to 36 weeks, where 90% will survive and 10% will have disability. And therein lies also the importance of making sure you bring them to the right center to get the right type of care. So abdominal exam, again, we kind of brought up what to expect at a particular gestational age. So remember, you expect the uterus to be much larger at 36 weeks as opposed to 20 weeks. So when you're feeling the belly and you're like, oh my God, what is this? Most likely we're dealing with, a uterus that's growing because of a baby. The uterus can displace other structures, which makes it slightly safer for those other organ systems, believe it or not. So if your bowel occupies that space for the entirety of your life, well, during pregnancy, your bowel is pushed away, the appendix is pushed away. And so normally when we talk about appendicitis, we anticipate right lower quadrant pain and tenderness. Well, guess what? During pregnancy, it might be mid flank, it might be right upper quadrant. So therein lies also the physiological structural changes of pregnancy may ultimately change your perception of the physical exam, which is important. When you talk about evaluating the uterus, yes, it's a hard muscle, but therein lies also the understanding what changes with certain obstetrical complications. So is it rigid? Is it tender? And in which case you may anticipate or expect that you're dealing with an abruption, or you're dealing with a rupture, or guess what? You may be dealing with somebody who's now in labor, right? Are these contractions, this rigidity coming and going like a wave ultimately? Pelvic exam. So again, it's a very sensitive area. We're talking about one of the more sensitive areas for any person when you talk about genitalia, and especially when it comes to a woman, especially during pregnancy. So it does require an area of professionalism, an area of training that, unfortunately, we don't necessarily even anticipate or expect our paramedics to do. And it's a topic of conversation Dr. Williams and I have had for quite a while about whether or not that should be done in order to properly evaluate the pregnant patient. And in doing so, you're evaluating 3 things. You're evaluating to determine if they're bleeding, which is important for abruption. You're evaluating to determine if their cervix is dilated, which is important for labor. And you're also evaluating to determine whether or not you're seeing amniotic fluid, which also may be a sign that they now broken their water and now they may also go into labor. So these are all important things that without doing that, you're always going to think the worst, and you're always going to send them to a facility that may not be the right one for them. So assuming this wasn't a pregnant patient and you're dealing with somebody who is having a heart attack or a stroke, it's important that in order for that to send them to the right center, you evaluate them in the most comprehensive way. The same thing should be said for the obstetrical patient, which is an argument that I've been bringing up for quite a while, and something that I think needs to change the world over. So fetal testing is important. And it's something that I think should be on any truck, which unfortunately we don't see. And I think it's an important aspect to have because it also will give you more information about whether or not to send mom and baby to which specific center, depending on what you're seeing. And so heart rate, if you hear a heart rate, if you're able to ascertain a heart rate, well, guess what? You're ultimately telling yourself and your team that the baby is alive. If you can't, then you need a sonogram to determine whether or not you're dealing with a stillbirth or unfortunately a fetal demise. And depending on the normalcy or abnormality of your fetal heart rate tracing, that should really tell you whether or not to send them to a facility. So what you're looking at here is a very bad tracing. Without going into specifics, what you're looking at here is what we refer to as a sinusoidal fetal heart rate pattern. And for those who remember trigonometry, math, the sine wave, ultimately, if you see that, what you're seeing in essence is a fetal hemorrhage. A baby who's most likely anemic, critically anemic, and these are the tracings which we rarely see. I may be, in my 15 years of practice, have only seen this once, really represents an acute situation that requires immediate delivery, and you have to get the baby to the closest place possible. But the fetal heart rate, there is a great variation. And so Dr. Williams brought up the adult EKG, which also has great variation. The fetal heart rate can represent complete normal, which is on your left, to something that is slightly abnormal, not slightly, but really abnormal on the right. But therein lies also the importance of understanding the difference between normal versus abnormal, because normalcy gives you time. Abnormality gives you less time. And depending on whether or not how well you can read this fetal EKG, not an adult, but a fetal EKG, should give you an understanding of triage, whether or not, again, center A, center B, or center C. Sonography is important, and not to necessarily say that we should all be masters at fetal sonography, but there are certain things you could pick up on. And particularly, we're going to go over that when it comes to certain complications. So management. Dr. Williams did a great job describing how to manage the I guess trauma patient. It's the same thing really for the pregnant, but obviously you're focusing also on the baby. So ABCs are important: airway, breathing, circulation, stabilize and transport, right? So if you stabilize mom, you stabilize the baby, all right? Anything happens as far as abnormalities to the fetal heart rate, guess what? If you return mom to a hemodynamic state, you're ultimately going to do the same thing for the baby. You want to recognize certain complications. So the abruptions are going to be important. The uterine ruptures are going to be important. The fetal bleeding is going to be important. And that obviously is important when it comes to trauma, because again, the uterus, if you remember, is such a large target. And so you want to kind of keep those complications in mind. Special circumstances, even in pregnancy, include Rh negative isoimmunization and the use of corticosteroids to promote fetal lung maturity in a preterm delivery. So initial approach, when you talk about the ABCs, certain things you want to kind of really focus on when it comes to pregnancy is oxygenation, maintaining at least an oxygen saturation of at least 95%. Keep in mind the increased risk of aspiration, right? So if you want to really kind of relax things and minimize that, consider rapid sequence intubation, consider obviously suctioning, cricoid pressure as a way to reduce the risk of aspiration, but be prepared for that in the pregnant patient. Circulation is going to also be super important, and especially because of the greater risk of exsanguination, loss of blood, large amounts of blood in a quick amount of time. You want to make sure you have the 2 large IV bores. You want to make sure you're able to give them rapid volume replacement. And if you have access to blood, even on the truck, I would suggest you do that immediately, especially in the trauma patient. CPR. So this is something that we, obviously come across very rarely, but when we talk about CPR in a pregnant patient, ultimately a couple of things need to change. So there is reduced efficacy in cardiopulmonary resuscitation, particularly with compressions. And that has to do with the reduced chest compliance, all right? One of the things you want to focus on is evacuating the uterus. Remember, there's reduced chest compliance because you have this wonderful uterus really in the way of doing what you're supposed to do as a provider. And so if, heaven forbid, you come across a cardiac arrest during pregnancy, you deliver as quickly as you can. Get them to the center as quickly as you can. And the rule is under 5 minutes. With compressions ongoing from the time that they go into cardiac arrest. If you get them out, the baby out under 5 minutes, they will survive. With after 5 minutes, the survival rate drops down exponentially, and after 15 minutes, statistically, it's a 5% survival. And we're not even talking about disability, clearly. We're just talking about survival. Placental abruption, right? Separation of the placenta can occur again with indirect or direct trauma, which makes it so important. So you have a patient who comes in who says, I just fell, but I fell on my butt. Well, guess what? It's still a problem. It's still something that you have to kind of evaluate and make sure the baby and mom are doing well. The problem with sonography when it comes to placental abruption is that it is super specific, but lacks a great amount of sensitivity. And so very rarely will you ever pick up an abruption on sonography, but if you do, you'll never miss it. And what I'm showing you here is an acute bleed versus an organized clot, and it looks very different. So it's important as a provider to identify those if you can on sonography. But again, sonography, very rarely will you ever see it on an abruption on sonography. You often look for your clinical signs, pain, bleeding, and then also on the fetal heart rate monitor, you see an abnormality as far as heart rate drop. Uterine rupture, whether it's more commonly, you'll end up seeing it in a penetrating trauma injury. But if you have a patient who is abrupting, if you have a patient who had a previous C-section, previous uterine surgery, and had some sort of trauma to it, anticipate that this may also happen. Signs and symptoms, again, you look for things like a surgical abdomen, you look for hemodynamic instability, you look for vaginal bleeding. On the fetal heart rate monitor, you see what we refer to as late decelerations. And I encourage for those obstetricians in the room to even teach your non-obstetrical providers and colleagues what that means, but it ultimately refers to a heart rate drop after a contraction. And again, the management is always the same: stabilize, deliver, and repair. Fetal maternal hemorrhage, whether it's because of placental abruption, because of cord avulsion, because of whatever may cause the fetal bleed, is again is something you may not necessarily be readily able to identify unless you look at a fetal heart rate monitor. And going back to that previous image of the sinusoidal fetal heart rate pattern would give you evidence to tell you this is going on. Clyard Betke, it's something that we use in the hospital setting, which kind of also tells us whether or not someone has had a fetal bleed, which is going to be important when you're dealing with Rh negative patients, right? So this is also going to be something you want to at least determine when you're in the field, not necessarily through this specific study, because obviously who has this in their trucks, but more so you could just ask, what is your blood type? If you happen to know, are you Rh negative? Do you happen to need an injection to treat this blood type? And so if you're able to get that information from the patient and have it on the truck, it would be beneficial, especially in the trauma setting. Preterm delivery, again, with your pelvic exam, if you feel as though the cervix is dilated, it's important then you take them to the closest facility. However, if you're able to do a pelvic exam and determine the patient is not delivering or not in labor, then you have an opportunity to take them not only to the right facility, but to the doctor that's been taking care of them, because that doctor, that facility may have their records in order to give them the best type of care. The purpose of the preterm delivery slide is really to also focus on how do you prepare, how does the paramedic and the EMS team prepare a patient for preterm delivery. And the best thing to do, and this also goes back to the slide on viability, how do you improve these babies' chances of survival and decreased disability? And that's really corticosteroids. I'm pretty sure the pediatricians in the room and the obstetricians realize the importance of corticosteroids when it comes to fetal and neonatal pulmonary maturity. And it's important to give that to the mom if they are potentially going to deliver prior to 37 weeks. And that is it, ladies and gentlemen. So I see that we do have a couple of questions, so I'm just going to open that up. And let's just, so from Albina, this is for Dr. Williams. The first question is, how will I understand that there is a spinal trauma, and how will I check the airway if I suspect such trauma? Thank you. I'm a pediatrician.
So when you suspect trauma, it's going to be really in the history, the etiology of the injury. So any significant trauma like an MVA, especially with peds, I know, one of the most common sources of their demise is motor vehicle accidents. It's, one of the #1 killers here in America, at least. And so you really want to take spinal precautions with all pediatric patients. And so you'll obviously apply a C-spine collar. And if you understand that there is spinal trauma, the best way to do it is ultimately they're going to need imaging. So you're going to need a CAT scan, but in the interim, you want to keep that spine as secured as possible. So if you're bringing them out from the field, we're talking about a backboard, we're talking about a C-spine, which will keep that C-spine collar, which will keep that spine intact and not manipulated. And when you're manipulating the airway in that patient, as opposed to pushing that head up and down and manipulating that C-spine, you would only grab it by the mandible and use our jaw thrust technique that we had spoke of to push the jaw forward. And that'll give you a straight line into the airway.
And the other question. Could IO insertion be painful for the patient? Do we sometimes need to use local anesthetics, for example, for the children?
Absolutely. And one of my favorite ways to do that is you actually flush the line with a little bit of lidocaine. And so you'll follow with the saline flush, and you put it right as you're drilling it in. You can flush with lidocaine before it enters into the space. It could be potentially painful. In fact, I actually only prefer to use it in unconscious trauma patients specifically. However, if there was no way to get IV access, and this is one of the reasons why you want to make sure that you're looking for your intravascular access first, and you're going for the intraosseous access if your intravascular access has failed, or if it looks like it's going to be an impossible thing to achieve, then you'll go for the IL. In the unconscious patient, it's almost equivalent, but in the conscious patient, if you were forced to use an IL, you would flush first with lidocaine.
Great questions, guys, so far. Should we do the chest compressions to a pregnant patient if the delivery is not possible in the nearest time, for example, in the field? So I would best answer that the same way I think Dr. Williams would, in that if a person has undergone cardiac arrest, you start chest compressions, because the most important thing for the life support of that patient is circulation. And so you start your cardiac compressions and you get them to the nearest center as soon as possible. If nothing else, what you would do in those initial seconds will mean the difference between life, death, and quality of life for that patient. So absolutely, regardless of whether or not you can deliver, you start CPR immediately.
And something that helps with the pregnant arrest, which is always a nightmare, so hopefully we won't have to put this into practice, but the truth is, if you have a board that stabilizes the upper patient of the upper body of the patient, and then you offset, much like Dr. Yunayev had mentioned, with the left lateral recumbent position. If you imitate that left lateral recumbent position enough where you're making sure that that uterus isn't or is not compromising your compressions at least a little bit, you could do that by doing compressions on an angle, right? And so that uterus kind of falls to the left lateral recumbent. It comes off of compressing and decreasing the effectiveness of your compressions. And you're kind of doing CPR on an angle on a backboard. So you can do that in real time.
Great question, guys. There's, ultimately one of the focuses that we want to offer, I guess, your group, is in the future, if we have an opportunity to do this in Ukraine, is not only do this as a lecture, but offer you guys this as a practical. So for you guys to practice what we do in the field, not only for the adult trauma, pediatric trauma, but also the pregnant patient. So, we're looking forward to obviously continuing this relationship, and hopefully offering this one day in person, when obviously this craziness around us is behind us. But I think the practical to this, hearing this and learning it through lecture or reading, I think is one thing. It's another thing when you actually could hold it in your hands and understand what it means to do a chest compression on non-pregnant and pregnant, or do an intubation. And therein lies, I guess, the art of the practice of medicine. And it can only happen when you actually get your hands on the patient. So, okay. All right. Next question: should we put a pregnant patient in a different position, for example, slightly lateral while performing? So, okay, we kind of absolutely. So, just because of the changes during pregnancy, the mechanical changes, absolutely, left lateral would be the optimal approach if you can, in getting the patient, I think, a greater chance of more effective compressions during the time of cardiac arrest. So absolutely, if you can. If you can't, then you start whatever you can, whatever works, so absolutely. But to your point, lateral would be better.